Thank you for that, and good morning, everyone. And a great pleasure to chair and manage this esteemed panel, which will begin to assemble. Do you want to come up onto the stage now so people can ogle you and see what talent we have? Just before we get into the panel, and I don't know if there's a slide about the panel, but you've got biogs in your pack for all but one of the members, who's a change. Instead of Anne Greenlee, we have Jackie Park from the North of England Commissioning Support Unit. Otherwise, the other panel members are in your pack. There's the panel there. And we're going to go into the panel in a moment or two, but just a couple of things I have to do in terms of my briefing. And before I hand over at 12:24 precisely to Paula, so we have just over an hour for this session. And as I say, once we've had the panel, brief presentations, we'll open it up to discussion on the floor. But a couple of things. Just a reminder to complete your 3 burning issues on your postcards. Don't set them alight, but if you have any burning issues you want to write down, please do, and they'll be collected in at the end of this session as you leave for lunch. I've also been asked if I would just give a little sort of sample of some of the issues emerging from the interim report on setting up a best practice partnership. And this follows some preliminary work that's been done by John Woodhouse and Margaret Stewart in relation to what NEQOS would like to know in terms of what do we need to understand better by way of what the key issues and challenges are in terms of what best practice might become across the region, how we might best promote it. And taking the views of various stakeholders has been the purpose of this initial exercise. So I'm just going to pick out, you've got a brief summary of this in your pack, an A5 flyer thing here, which talks about some of the key issues. And I'm just going to pick out a few points in my 5 minutes or so, and then hopefully that'll extend into what the panel might pick up on and what we'll then discuss in plenary. So clearly what's coming through these initial interviews is that this is a really important and timely initiative, and there are already lots of good things happening across the region. Effective systems for sharing good practice do exist, and they do work well for a lot of the time, but there's a general perception that there's an absence of a regional forum. Seamus said at the beginning that we're in a very complex, very fragmented environment in terms of the new NHS, and we're all grappling with that still, 7-8 months on. And what's missing, I think, what is a sense, the element in the room, is that kind of regional forum. For a time we couldn't use the R word, but I think it's come back into the vocabulary. But there is a need, I think, for some body across the North East. The North East has always had a kind of regional feel about it, and some of the regional institutions are still being maintained, despite the feeling that we can't have organisations at intermediate level. So a perception that we need some forum to allow better sharing of good practice and issues and knowledge and so on. A third point would be that where the secondary care sector seems to be reasonably robust and well developed in terms of a commitment to a best practice partnership, and it's seen as valuable and there's already active participation in that, maybe the position in primary care is a little less clear in respect of the role and relationships concerning CCGs and their links with the Commissioning Support Unit. And it might be that, although it's early days and CCGs are particularly new bodies, there could be scope for development and improvement in that area in respect of commissioning system development across the patch. So that may be something we want to pick up in the panel presentations and also in the discussion after. That maybe the scope in primary care in particular around commissioning is an area for development. Fourth point, and there are 8 of these, so you'll know when I'm getting to the end, I'm halfway through now. Vertical integration between primary and secondary care is evident in some areas and some trusts across the region, and that can result in better joining up between the sectors. That is the point of vertical integration, and it does seem to have an impact. But where there are pan or cross-organisational issues arising in relation to commissioning or patient care or getting evidence into practice, getting effective joined-up working is more complex and difficult. And paradoxically, where you have good vertical integration, it might make horizontal working more difficult. So there's an issue about how you balance vertical and horizontal and how we develop the pan or cross-organisational agenda. And then 6, and not surprisingly, key to all of this is effective communication and trust. The kind of softer intangibles are critical. Relationship building. At the end of the day, it isn't about structures. It's about working in terms of relationships and developing those relationships, which is difficult when we've all had the structural upheaval we've gone through. But again, maintaining continuity and some sense of communication and trust between key individuals is going to be critical to all of this. Allied to which is the need for clear enthusiasts, the kind of champions, the product champions who will drive the partnerships is also key. And identifying those individuals is critical. And a final point, where within trust there's a kind of willingness to let go and devolve responsibility, those trusts seem to do better in terms of developing good and best practice and implementing it than trusts where perhaps there's more of a tendency to centralise and keep control at higher levels. So again, something about devolution and localism being important in regard to how one progresses best partnership working across the piece. So those are just some key points that occurred to me reading through the material I was given. I think they're issues that will resonate with some of you. If I've got anything wrong or I've missed anything, I'm sure John Wooters will stand up and say so at some point. But I won't encourage him to just yet. But as I say, we can pick those and other issues up in the discussion, because I'm sure some of them will be important for you too. But it does mean that these are issues that the work will pick up on in the next stage in terms of the deep dives that are now planned to look at how some of those points can be developed and taken forward further in the context of the best practice partnership. So that's just a kind of taster, and hopefully might chime and echo with some of the points that might come up later. But let's turn to the panel now, and we'll start at the end with Chris Drinkwater, and we'll move up to, we'll skip Richard because he's had his say, and then we'll move up the panel to Andrew, and then we'll stop when we get to Andrew, and then we'll have some questions from the floor, and then we'll turn to the panel. So Chris, 5 minutes to give your perspective on a best practice partnership.
Thank you very much, David, and good morning, everybody. Collaboration. I wanted to focus on and talk about the need for collaboration between the social model of care and the medical model of care, because they are two very different perspectives, and collaboration is about understanding the perspectives of the people that you're working with. Interesting article in this week's British Medical Journal that says here around a third of people in the United States and Europe experience chronic pain. It then goes on to say that the drugs that we have don't really work. And one of the reasons they don't really work is that pain is altered by emotional and social factors. So emotional and social factors are there. It then follows this by what I see as a somewhat remarkable conclusion, and says, in order to develop better treatments, we need animal models that account for comorbidities such as depression. i.e. we need some depressed alcoholic rats that we can test out, and more nuanced behavioural assessment tools, deeper understanding of how changes on brain imaging relate to behaviours and responses to treatment, and a range of biomarkers and genomic tools to differentiate pain types and formulate individualised treatments. What happened to the social and emotional factors? Because actually, in a GP surgery at the end of the week, you think about the people you've dealt with chronic pain. Pain is a metaphor for social and psychological distress. We need to think about how we address the social factors and not go down this route of addressing the medical factors. Yes, it will get you so far, but it's unlikely to solve the problems that we face in the 21st century in terms of healthcare. I'm very passionate about social prescribing. I'm now chair of something called Ways to Wellness, which is a company limited by shares, which sits within Voluntary Organisations Network North East, and is the first recipient of the big lottery commissioning for better outcome funds. So we're the first organisation to get any funding from them, £150,000 to do some more development work so that we can develop a social impact bond model of social prescribing for people with long-term conditions, i.e. generic long-term conditions, not a specific condition. We want to deal with all long-term conditions because the similarities between people with long-term conditions is about people living in their social context, i.e. within their family, within their local community. And it's that that's more likely to determine a successful outcome than anything that we do as doctors. So I'm fairly committed to social prescribing. I don't have time to talk about it in detail, but if you want to hear more, there's a presentation in Fuse at the beginning of March in Newcastle, so you're all very welcome to come to that. So there are solutions. We can begin to look at social prescribing models, which are about sort of access to a range of supportive activities that help people to develop local social networks, develop the confidence to be able to care for themselves and to take more responsibility for their own care. And all the evidence is increasingly that that is a very effective way forward. My 5 minutes is nearly up. I wanted to end just by going back to the rats and thinking about the rats. And there's a nice little story about what's the difference between rats and humans. Well, if you're a big experimenter and you've got a bunch of rats and you construct a nice little maze with various tunnels and you put cheese at the end of one of the tunnels, the rats rapidly discover which tunnel to go down to get the cheese. If you then remove the cheese, it doesn't take very long for the rats to lose interest and not bother with the maze, because actually there's no reward there. The difference between rats and humans is if you do the same thing with humans, we become to believe in the cheese, so we keep on going down the tunnel forever and ever. And there are some issues about we need to think seriously about our belief systems. And if our prevailing belief system is the medical model and fix it, well, we need to sort of begin to think about, is that producing the rewards of our investment that we want? Or do we need to think a little bit more laterally and begin to invest in social value and social reward, basically? Thank you.
Thank you, Chris. Okay, we'll leave it to ponder on the rats and the cheese. Maybe the type of cheese matters too, does it? I don't know.
Not very much, actually.
Right. We haven't got Anne Greenley here, but Jackie Parks very kindly agreed to step in. So introduce yourself, Jackie. And
hello, yes, morning. I'm very pleased to take the opportunity to be here. Partly, really, I suppose, because the fact that I am here is a recognition that North of England Commissioning Support as a piece of the jigsaw is at least recognised that we've got something to contribute. And on that basis, I just thought it would be very helpful to just give you a little bit about who we are. I have shared some slides that I'm sure can go around to people after this. But there's really the whole focus of this is about how does the evidence get turned into practice, which actually delivers improved outcomes for the communities, the people out there. And essentially, commissioning support organisations, there are 19 across the country, were set up to support commissioners to be able to focus, particularly clinical commissions, be able to focus on strategy, but us be able to provide them with the services to support taking that through into, as I say, delivery and improved outcomes. We provide a full range of commissioning services. We do that across the North East and Cumbria, 13 clinical commissioning groups, but a range of other organisations, also further afield across the country. So not only can we connect up organisations in the North East and Cumbria, but we've also got access to our commissioning support colleagues and networks across the country. So I think there's really something that we can add there as to how we help with that. We have over 800 staff, so again, they've got a vast range of experience and expertise across the healthcare system, not just in commissioning, but in provision, local authorities. So again, a big resource there that can contribute to what we're aiming to achieve. In terms of the regional partnership, for all of those reasons, I think we would be very keen to be involved in that and to be making sure that every pound that is spent on health is spent effectively. We don't want to be working with and duplicating across organisational boundaries. We absolutely do need to make sure that there's no waste, and we focus on that. So I think the regional partnership will be a great thing for us to be involved in. And in terms of just an example of where we're already doing some collaboration, on behalf of the 13 clinical commissioning groups in the North Eastern Cumbria, one of the big challenges that they've described is how do you take that evidence into implementation in the local context, and the local context is always really important. No matter how strong the evidence is and how compelling the story, you've still got to turn that into a reality in your local context. So we've been developing a commissioning knowledge hub, particularly on that basis, and that's not about reproducing the evidence that is available from NICE and lots of other organisations, but is really about collecting case studies and connecting people in the North Eastern Cumbria around what have you done? What have you actually achieved? What did you learn from that? What have you got to share with others? And there's a website that's been launched. The clinical commissioning groups have been working with us to start to build a bank of case studies, so that you can go in there, you can do a quick search before you actually start a piece of work, find out if that's already been done in the North Eastern Cumbria, and actually find someone to contact. And there's also they're developing quick tips, so you can get in there pretty quickly. So I think that's got a huge potential, and that's really where I think we fit with that, is being able to connect the evidence with the people on the ground and how they actually implement that in their local context, which is what everybody here is about. It's about the outcomes for patients and communities at the end of the day. And so, as I say, we're very pleased to be involved in this.
Thank you. Peter?
Hi, good morning. I'm Peter Weaving. I'm a GP and clinical director of a challenged trust in Cumbria, which narrows it down to 3. I'm the least qualified person to talk to you. My last qualification was a certificate in substance misuse, which I received 20 years ago. So I thought it was helpful if I gave you both a historic and a grassroots view of some of the issues which have been discussed already this morning. I'm not exactly ancient, but when I was a medical student, I was taught by the inventor of beta blockers. Cimetidine didn't exist, let alone PPIs and SSRIs and most of the drugs and other acronyms we take for granted nowadays, apart from diuretics and digitalis. They were but a twinkle in some pharmacologist's eye. The BNF was a little blue hardback book which spoke to me of grains of phenobarbital. Patients suffering heart attacks fell into 2 groups, those that died and those that didn't. They were both treated in the same way with bed rest and TLC, but no other intervention. Common cancers such as testicular teratoma, along with Hodgkin's, were fairly invariably fatal. As a GP, I was the ultimate generalist, knowing virtually nothing about virtually everything. We delivered babies at home on the floor or in makeshift birthing pools. I watched untrained colleagues anaesthetise patients in community hospitals. That barefoot doctor, me, is now faced with patients who arrive backed by Dr. Google and reams of printout, which to me is a learning opportunity, but I know it brings a large number of my clinical colleagues out in hives. As does the arrival of a patient armed with a detailed side effect leaflet for any medication for which they've been prescribed. The poor woman with fibroids pushing up towards her umbilicus is not very interested in a highly effective hysterectomy performed locally. She would like to exercise her right to have her fibroids shrunk by monthly GnRH injections before the latest laser ablation from St Elsewhere's. To navigate this increasingly scary territory, I need powerful, effective, and very up-to-date allies. I need nice guidance on my iPad, and I need this half year's BNF on my desk. I need to know the evidence on each is accurate, dispassionate, and free from undue influence by enthusiasts, entrepreneurs, or the industries of drugs and devices. My right hip hurts. My 87-year-old mother with 2 new hips describes cheerfully and accurately my exact symptoms and their likely progress. Before you reach for the Kleenex, I would like to point out that I had a very nice skiing holiday last week, so thank you for your concern. However, but what about hip resurfacing as an intermediate stage? Ask nice. Eventually, I will have a total hip replacement. Which procedure? Which prosthesis? I could spend $8,000 in Scandinavia routinely, or $60,000 routinely in the USA. At the end of the day, you, the people sitting here, either as the health payer or through your taxes, will pay for that difference. Maybe it isn't osteoarthritis. Maybe I've got bone secondaries from my hitherto undetected prostate cancer. Shouldn't NICE and your networks have implemented a screening programme? To date, for a variety of reasons, no, they shouldn't. But what am I going to do? Bisphosphonates, monoclonal antibodies, hormonal manipulation, radiotherapy, orthopaedic surgery. As an expert generalist, even I need a good navigator here. I need the best advice, therefore so do my patients, and I need my clinical colleagues to follow it, whether in Carlisle, Newcastle, or the Christie. Knowledge is power, and now everyone has easy access to it. It's even more important that our clinical knowledge, is consistent and universally applied, untainted by bias or fear or favour. Thank you.
Hi, good morning. I'm Ian Rennick. I'm the Chief Executive at the QE Gateshead. I've learned through 30 years of work in the public sector the pitfalls of following probably the wittiest member of the panel, and also the first one to get a round of applause. So I'll do my very best to follow that. I'm a predominantly DGH-based service chief executive. Worse than that, I'm an accountant as well, but I do describe myself as an accountant in recovery, having been a chief exec for about 7 years. So why am I here? Well, something that David said earlier on kind of resonated with me about the need to find something to step into what is definitely a void in the system at the minute. Being a secondary care chief executive and an accountant, I describe myself probably as a healthy cynic. Or a cynical enthusiast around being here today, because it strikes me that I'm probably part of that community that David was referring to when he talked about people clamouring for something to step into the void and give us some best practice to work on and cut our teeth on, because we generally tend to moan about the absence of things like that, and that's generally because we're desperate to have someone else to blame for our inactivity. And then of course we get some kind of regional body set up and we moan about them as well, because they're not doing exactly what we want them to do and exactly the way that we want them to do it. But I'm a great believer in the collaboration agenda versus, if that's a question of collaboration, as against competition, in the way that we should be delivering care to people. And I don't just talk about hospital care, I mean whole system care. And David also talked about that tension between vertical and horizontal integration. And it would be easy for me as a cynical accountant to sit here and moan about money. I could talk to you about tariff deflators until I'm blue in the face, and I can talk to you about the Better Care Fund. And you're probably all close to people who talk to you about that kind of thing on a day-to-day basis. I generally tend to try not to moan about those things, because rather than seeing them as risks, I'm a great believer that there must be opportunity in there somewhere. And I think that the tariff deflator and the Better Care Fund exists for a reason. And that's so that people like me and people like the fantastic organisation, the 3,500 people who work in the fantastic organisation that I'm privileged to manage, it's so the system can leverage out the enormous enthusiasm and track record that we've got around partnership, around change. It's just someone seems to be looking for that magic key. You can't go anywhere without hearing somebody talk about the I word, integration. And other than some notable examples in places like Torbay and North London, I think we all know what the problem is, but few of us really have got ourselves to a point of having a wholesale solution. So what I'm really hoping to come out with things like the local partnership is that we can work together in a truly collaborative way. And actually, I'm going to challenge, I think, with something that David might have said, not about implementing best practice, but actually about developing it. Someone's got to be the leader somewhere. And Jackie and I were talking earlier on about the enormous amount of talent there is in the NHS and in all of our partner and stakeholder organisations across social care, across the independent sector, across the voluntary sector. Why not harness some of that and be leaders in this as opposed to being followers?
Do we give you an applause?
No. Not if it wasn't spontaneously worth it.
No, you stunned everyone with that last comment, Ian. That was the issue, I think. We were just digesting it.
I haven't been too long.
Okay, thanks very much for that, for those 4 perspectives. I think in terms of what Paula asked earlier about how we go forward, there are some key points emerging. None of them are new. And the thing about the NHS is we often know what to do. We're just not very good at always doing it. So issues about common cause, resource control, sustainable engagement, ownership, leadership, but not just any old leadership, particular style of leadership, engaged leadership, as Beverly Alamo Metcalf puts it, where you engage with the people who need to own the issue, in a sense. All of these are familiar nostrums that we preach endlessly in the NHS. The real thing is doing it, I think, and making it a reality. We know what to do, we just aren't always very good at following through and doing it consistently, and doing that in a context where relationships and communication and trust are really important. And I think if we can capture all that in the best practice partnership, then I think we will have learned from the past and we will be able to take things forward. So thanks for that. No one's put their hand up and said this is a bad idea and this is terrible and we shouldn't be doing this. So I assume silence denotes consent. So that's positive. We'll go into lunch now, but let me hand over to Paula and thank our panel, esteemed panel, for behaving pretty well in the circumstances. Thank you.